Welcome to our video on viral skin infections. Let's get started. So in this section, we'll go through these viral skin infections, starting with shingles. Now we'll briefly go over the introduction, risk factors, pathophys, clinical presentation, as well as the diagnosis, management, and complications. And we're going to start with introduction. Shingles is also known as herpes zoster infection that occurs as a reactivation of varicella zoster virus, or VZV. Varicella zoster virus lies in its dormant phase in the dorsal root ganglion after its primary infection during childhood. The risk factors of shingles are more like the risk factors of virus reactivation. It commonly affects people of more than 50 years of age, and this is the most helpful, important risk factor. Other risk factors include malnutrition and immunocompromised states, for example, malignancy, HIV infection, and transplant patients. All of these are related to decreased immune function in patients that will have increased risk for virus reactivation. Now, the virus is transmitted via respiratory droplets and direct contact with an infected person during the infective stage of the disease, which starts 1 to 2 days before the onset of a rash. Now, chickenpox is the primary infection, which occurs during childhood, and the virus infects the nasopharyngeal lymphoid tissue and later disseminates, causing viremia and chickenpox. After the initial infection and recovery, varicella zoster virus, VZV, remains dormant in the dorsal root ganglion, as we mentioned a moment ago. Virus reactivation and replication occurs many years after that primary infection, and it's due to the various etiologies we discussed before. Basically, anything that can increase the risk of virus reactivation, like immunosuppression. So, once reactivated, the virus then travels along the sensory nerve axons and cause a rash along an involved dermatome. The most common presenting complaint is severe itching and burning pain that may occur before the appearance of any rash. Now, patients may also complain of an exaggerated pain sensation with a stimulus that is not normally painful, and that's termed allodynia. Now, the typical rash in these patients is characterized by the presence of erythematous papules and vesicles, and they may be clustered along the involved dermatome. Now, it typically has a unilateral dermatomal distribution, affecting 1 to 3 dermatomes. Fever and malaise may also be present. The most commonly involved site is the thorax. However, ophthalmic division of the trigeminal nerve can also be involved, as well as cervical and lumbar regions. Here's a picture of a patient with herpes zoster infection. Notice the one-sided dermatomal distribution of this rash and the raised erythematous nature of it. So now let's figure out the dermatome involved in this particular case. Using this image, we can determine the dermatome involved. 2 main dermatomes to remember in the torso are the T4 that corresponds to the nipple line and the T10 that corresponds to the umbilicus. The rash present in the previous picture was just above the nipple, which means that the involved dermatome is above T4, probably the T3 dermatome. The diagnosis is based on history and clinical findings of typical erythematous and vesicular rash. Polymerase chain reaction test can be used as a confirmatory test, as it can help detect that viral DNA. And the specimens that can be used for this test are the vesicular lesion fluid, as well as the CSF and the blood. Now let's move on to the management. Antiviral drugs, such as acyclovir and valacyclovir, should be prescribed within 72 hours of symptom onset. This shortens the course of the disease, it reduces pain, and decreases the risk of post-herpetic neuralgia. Now, as pain may be severe, it can be managed by analgesics, such as NSAIDs. As the skin lesions crust and may become necrotic, wound care is a must, and it should be cleaned regularly to prevent any secondary infections. Lastly, a recombinant herpes zoster vaccine is recommended for patients aged 60 or older. Live vaccines are contraindicated in the elderly population because they have a weaker immune system. Now let's move on to complications. Post-herpetic neuralgia is the most common complication of shingles. It is characterized by persistence of burning pain for more than 3 months over the area previously affected by herpes zoster infection. The first-line treatment of post-herpetic neuralgia includes pregabalin and gabapentin. Tricyclic antidepressants like amitriptyline are also frequently used, particularly in patients who have severe pain and are unable to tolerate gabapentin or pregabalin. The next complication we'll focus on is herpes zoster ophthalmicus. It is characterized by VZV reactivation involving the ophthalmic division of the trigeminal nerve. Recall that this branch of the trigeminal nerve innervates the skin and mucous membrane of the upper face and scalp, and patients may present with features of conjunctivitis and keratitis, such as redness, itching, pain, and watering or eye discharge. They may also present with headache, fever, and a rash, along with the eye symptoms. Now, herpes zoster oticus, which is also known as the Ramsay-Hunt syndrome, occurs when the virus reactivation involves facial and vestibulocochlear nerves, and patients present with a triad of features that includes ipsilateral facial paralysis, because it's got the facial nerve, as well as earache and a vesicular rash along the external auditory canal in the pinna. Here's a picture that depicts the features of herpes zoster oticus, or Ramsay-Hunt syndrome. Notice the red rash over the right ear and features of facial paralysis on the right half of the face, such as no forehead wrinkles, widened eye, and no visible nasolabial folds, and of course, drooping of the right corner of the mouth. Let's move on to herpetic whitlow. We'll go through the introduction all the way down to the management, just like we did in the previous discussion. So let's start with the introduction. Herpetic whitlow is an infection of fingers caused by herpes simplex virus. Children are affected by herpes simplex virus type 1, HSV1, and adults can be affected by both type 1 and type 2, although HSV2 is more common in adults. Now, this infection is characterized by a bimodal age distribution and affects children less than 10 years old and adults between 20 to 30 years. The virus is transmitted when a person comes in direct contact with secretions from an infected patient or carrier. After initial infection, the HSV virus remains latent in the sensory ganglion and may be reactivated later to cause recurrent infections. So, it commonly affects people with a disrupted skin barrier, and it also affects dentists, as they're frequently exposed to those respiratory secretions. Now, the terminal phalanx of the finger is the most common site involved. Patients present with pain, redness, and swelling of a finger, or sometimes multiple fingers. A cluster of vesicles is present at the site of infection, and it contains this clear or even purulent fluid. When the base of the vesicular rash is exposed, it reveals a typical honeycomb appearance, which is a diagnostic feature. Some patients may develop fever and lymphadenopathy. This is a typical picture of herpetic whitlow. The terminal phalanx looks red and swollen, and it has that vesicular rash. Herpetic whitlow is a clinical diagnosis. However, viral culture can be done to confirm the diagnosis. Other tests include serum antibody titers and a Zonk smear microscopy. The Zonk smear is not specific, and it doesn't really distinguish between HSV1 and HSV2. Herpetic whitlow usually resolves spontaneously in about 2 to 4 weeks. And during this period, conservative management such as rest and use of anti-inflammatory drugs may be required. Proper wound care is necessary to prevent secondary infection and to prevent further transmission. Now, topical or oral antiviral therapy may be needed in immunocompromised patients in order to shorten the disease course. Now let's move on to herpetic stomatitis. Herpetic stomatitis is the most common manifestation of the HSV infection, and it's caused by HSV type 1 and is characterized by multiple blisters in the oral mucosa and gingiva. It commonly affects children from 1 to 6 years and in people with immunocompromised states. The pathophysiology of herpetic stomatitis is similar to that of herpetic whitlow. Transmission of the virus occurs when a person comes in direct contact with the secretions from infected patients or carriers. The HSV virus remains latent in the nuclei of local nerves, and then it's reactivated by stress, sunlight, trauma, and immunosuppression. Now, patients usually present with an erythematous rash with a cluster of vesicles, and the vesicles may coalesce and form a painful ulcer. Fever, malaise, and headache may be present a few days before the rash. You can think of those as prodromal features. And the most commonly affected sites include the tongue, the buccal mucosa, the palate, lips, and the anterior pharynx. What is the difference between herpetic gingivostomatitis and herpangina? Okay, well, herpetic gingivostomatitis is a herpes simplex virus type 1 infection, and it involves the anterior pharynx. In contrast, herpangina is caused by Coxsackie A virus, and it involves the posterior pharynx. This is a picture of a patient with herpangina. The lesions appear herpes-like and occur in the oral cavity and the posterior pharynx, causing extreme pain. Herpes stomatitis is a clinical diagnosis, and it's based on the clinical features and history. However, polymerase chain reaction, PCR, and viral culture may be performed to confirm the diagnosis. The management of herpetic stomatitis is supportive, as it resolves spontaneously. The patient must be hydrated adequately, as patients avoid drinking due to the severe pain, which makes sense. If you're swallowing and it hurts, you're likely to become dehydrated from not drinking. Now, petroleum jelly can be used as lip creams over the oral lesions. Pain can be managed with analgesics such as acetaminophen or NSAIDs, and antiviral therapy with acyclovir should be initiated within 72 hours of symptom onset in order to shorten the course of the illness. Let's move on to Molluscum contagiosum. We will go through introduction all the way down through management. Molluscum contagiosum is a viral skin infection caused by a pox virus named Molluscum contagiosum and is a highly contagious disease as it can spread by skin-to-skin contact. Children less than 5 years and sexually active adults are commonly affected. This infection often requires no treatment because it's self-limiting. The main risk factor for the transmission is direct skin-to-skin contact, for example, in contact sports and sexual intercourse. Immunodeficient conditions like AIDS can also increase the risk of infection. And lastly, fomites can also be responsible for virus transmission. Now, patients usually present with raised, flesh-colored lesions with a characteristic central umbilication. These lesions may be polypoid and singular or multiple, and commonly involved sites include the trunk, axilla, groin, genitalia, proximal thighs, and face, and the palms and soles are spared. Here's a picture of a patient with Molluscum contagiosum. Notice that the lesions are raised and they're fleshy and umbilicated. Here's another picture where the characteristic central umbilication is clearly seen. The diagnosis of Molluscum contagiosum is based on history and clinical findings. On histologic examination, eosinophilic inclusion bodies can be seen within the cytoplasm of keratinocytes, and these are known as molluscum bodies. In atypical or disseminated cases, especially in adults with large or widespread lesions, HIV testing should be done, and HIV-positive cases should be treated with antiretroviral therapy. Most cases resolve spontaneously after a few months, and treatment may be needed if lesions don't resolve or the patient is immunocompromised. And the first-line therapy includes cryotherapy and curettage of the skin lesions. Topical treatments, such as imiquimod, cantharidin, and podophyllin, may also be used to remove the lesions. Finally, let's move on to our last topic, warts. Warts, or verrucae, is the infection of skin and mucous membranes by human papillomavirus, HPV. It's a benign condition, but recall that some strains of HPV can cause cancer, particularly HPV 16 and 18. Those cause cervical carcinoma. And the virus is transmitted by direct skin-to-skin contact or by sexual contact, in the case of anogenital warts. Anogenital warts are the most common sexually transmitted disease, and the strains responsible for those are HPV 6 and 11. Warts can be classically divided into two main types, cutaneous warts and anogenital warts. Cutaneous warts can be further divided into three subtypes. Now, the first one is called the common wart, or verruca vulgaris, which is the most common wart. And the second is a flat wart, or verruca plana. And the third one is a plantar wart, or verruca plantaris. Anogenital warts are called condylomata acuminata. Warts are very common and easily identified. It appears as fleshy, skin, or white-colored lesions, and they can have that rough surface or a cauliflower-like growth. Now, warts are usually painless, but plantar warts can be painful. Here's an image of our plantar wart. Notice the yellow-white rough appearance of the lesion, and that's fairly classic. Warts can appear almost anywhere in the body. Common warts are frequently present on fingers, elbows, knees. Flat warts are commonly located on the face or the dorsum of the hands. Plantar warts are usually located on the heel and the metatarsal heads, and anogenital warts commonly appear on the genitalia, perineum, and anus. So this is a typical exophytic cauliflower-like lesion in a patient with an anogenital wart, and these are skin-colored lesions around the perianal area. Warts are common and can be diagnosed clinically based on the characteristic appearance of the lesions. On dermoscopy, warts may contain black dots that represent thrombosed capillaries. Now, 5% acetic acid solution application on suspected lesions can turn the lesions white. And this is performed in anogenital warts. In anogenital warts, patients must also be treated for other sexually transmitted diseases, for example, chlamydia and gonorrhea. Cutaneous warts do not require any treatment, as spontaneous resolution occurs within 1 to 2 years. However, patients with plantar warts may require treatment. First-line treatments include topical salicylic acid and cryotherapy with liquid nitrogen to freeze the lesions. Anogenital warts, or condylomata acuminata, can be treated by various options. Topical therapies, including imiquimod, podophylotoxin, and trichloroacetic acid, can be given. Invasive therapy options include cryotherapy and surgical excision. HPV vaccination is a way of prevention and protects against various HPV strains, including HPV 6 and 11 that cause anogenital warts, and also HPV 16 and 18 that cause cervical cancer. Now, HPV vaccination is recommended for adolescents at 11 to 12 years of age, and a second dose is given after 12 months. and the HPV vaccine has been approved for use in the United States until the patient turns 45. How can we differentiate condylomata acuminata from condylomata lata? Now, condylomata acuminata is another term for anogenital warts that we've just discussed. Condylomata lata is a wart-like lesion seen in patients with secondary syphilis. Before we go through the table, it's worth mentioning that the appearance of these lesions is not a good indicator of which disease is present, since the genital lesions of secondary syphilis often imitate those of anogenital warts. This table is meant to simplify this question into 3 ways by which we can distinguish these two diseases. The first is the presence of a preceding lesion. A painless, reddened chancre is a classic initial presentation for primary syphilis, which can progress to secondary syphilis if untreated. Thus, condylomata lata will have a preceding lesion. In patients with anogenital warts, this preceding lesion is absent. In patients with condylomata acuminata, the genital warts, systemic symptoms don't present, such as fever or rash, whereas you would expect those in syphilis. In condylomata lata, however, patients will often have a fever, malaise, and a widespread maculopapular rash affecting the palms and soles. Finally, the response to treatment can be a way of ensuring if the correct diagnosis was made. Condylomata acuminata will not respond to penicillin, while condylomata lata will. So let's wrap up with a board-style question. An 84-year-old male comes to the physician due to pain on his chest. He reports that first he had a rash on the same area 6 months ago, which then disappeared. Now he only complains of pain. Past medical history is significant for chronic kidney disease stage 3 and tertiary syphilis. Vital signs are unremarkable. A physical exam shows an elderly male in significant distress while palpating his left mid-thoracic wall. Which of the following is the best treatment option for this patient's condition? A. Ibuprofen, B. Pregabalin, C. Amitriptyline, or D. Acetaminophen. Okay, so this question focuses on treatment of this patient's underlying disorder. Therefore, before we discuss the treatment, we should diagnose his disease. So this is an 84-year-old male with unilateral mid-thoracic wall pain preceded by a rash in the same distribution. He also exhibits allodynia, that is, pain sensation caused by normally painless stimuli, such as gentle palpation. Now, these signs and symptoms are consistent with post-herpetic neuralgia. And the first-line treatment of post-herpetic neuralgia is either gabapentin or pregabalin. Therefore, the correct answer is option B, pregabalin. Let's discuss why other options are incorrect. Option A, ibuprofen, is incorrect because although NSAIDs can work as analgesics, this patient has chronic kidney disease stage 3, so we will not give him NSAIDs because that can further decrease his GFR. Option C, amitriptyline, is sometimes used in the management of post-herpetic neuralgia. However, amitriptyline is an extremely sedating medication due to its histamine and muscarinic receptor blocking effects. And given that this patient is an elderly male and he has tertiary syphilis, possibly associated with tabes dorsalis, then extreme sedation can increase the risk of falls. It's just not ideal. It's dangerous in this population. So, amitriptyline, although reasonable, is not the best option in this patient. Now, option D, acetaminophen, can work as an analgesic. However, it's not the first-line treatment for post-herpetic neuralgia. And that concludes our lecture on viral skin infections.